Thank you very much for this opportunity. And I sort of start with this picture of the Hans Christian Andersen tale that you may all know very well, of the emperor walking down the road, wearing these new beautiful clothes. And of course, we as the so-called experts are, walking in front of you, proclaiming that we are wearing these beautiful clothes. And I really would like you to be like the little boy in the background there, to put their hand up and say, yeah, I'm not sure that the emperor is wearing new clothes, because a lot of what we are talking about at the moment is still very controversial, and we have to learn so much about this field. And yet you, in your clinical practices, are actually seeing the patients day by day. And I had an old boss that always used to say, the truth is in the patient. If you just ask them, they will tell you. And I certainly think that's where we can learn a great deal from our patients at the moment. Those are my conflicts of interest. And I actually put up a gastric bypass slide there because most of my research career I spent in actually trying to understand how operations such as the gastric bypass and gastric band work. And I joke with my surgical colleagues, and I say to them that, they have found the answer without understanding the questions. And what we now have to do is sort of back engineer it, because there's a lot that we can learn from this. And I think this meeting is fantastic, to actually have all the community that's interested in treating obesity together under one roof. So this is, if you're a general practitioner, this is what makes your life hell if you try and treat people with obesity. So what you have is you have patients coming into your clinic, you give them a new diet that came around, didn't work terribly well, patient comes back to your clinic, you give them a new diet or new approach, doesn't work terribly well, they come back to your clinic, you have another go with something else, and effectively the patient stops coming. And at that point, we as clinicians very often turn around and say, you see, I told you, they're just not motivated. In fact, there may be very little wrong with the motivation of the patient, but probably more wrong with the way we have approached the disease and what we've actually tried to do. So what we've been focusing on is maybe morbid obesity, and so many of our clinics have tried to chase kilograms or pounds, trying to make people less fat or less heavy. But in fact, what we probably should have done is just turn those two words around. Instead of focusing on morbid obesity, rather focus on obese morbidity. And actually thinking, what are the morbidities that actually makes our patients' lives harder, what actually drives their quality of life down, and actually even thinking about the symptomology of the disease. I'm not only talking about the complications of obesity, I really want us to examine this as a disease. Now, you will remember when we were back in medical school, we actually had to learn the definitions for what is a disease. Here's one of the definitions of a disease. But before I start, I'm going to ask you as an audience, and this is the bit where we're going to be interactive, and the really good news is there's no right or wrong answers, because everything we're going to discuss is incredibly controversial, so whatever you say is probably right. But, who in the audience actually here think that obesity is a disease? Raise your hand. Okay, so we have a lot of believers around here. There's a lot of people actually that do not think obesity is a disease, and I think, we need to make that point. But we say that any disease, represents a deviation from or an interruption of the normal structure or function of any body part. I'm going to come back to that, because I'm going to ask you in about 2 or 3 minutes, which body part or which organ is responsible for the pathogenesis of obesity. So what organ is responsible for the pathogenesis of obesity? So think about that while we actually think about, or system that manifested by characteristic set of symptoms and signs. So the signs of obesity is pretty easy. A patient walks through your door and within a couple of seconds whether or not this person is obese or not. You look them up and down, you've got a pretty good idea of what a BMI of 30 looks like, and you can actually look at the signs of obesity. But now I'm going to ask you in the audience, please tell me, what are the symptoms of obesity? So I'm not asking again the symptoms of the complications, no, not the symptoms of diabetes or the symptoms of osteoarthritis or the symptoms of sleep apnea. If we think that obesity is a disease, can anybody offer me a symptom of the disease? And if you don't offer me, I'm going to actually ask. So, any hands? Yes? Hunger. And sorry, you were saying at the back there? Hungry all the time. Yeah, and I would agree with you. I think the symptoms of the disease that we are treating is either hunger or a lack of satiety. And suddenly, if we understand, as Steve has actually showed us already, the neurobiology, now we actually are starting to understand that if this is a disease and the symptoms that we want to reduce is hunger, or we want to increase satiety, now we can actually start making a difference, as opposed to just trying to change the signs or the body weight. So now the next question, as I said, so which organ is responsible for the pathogenesis of obesity? So I'm going to give you guys 3 choices or 4 choices to choose from. The first is, and please, everybody has to vote, and this person in the back that's counting the votes, so everybody has to vote. And as I say, there's no right or wrong answers here. It's really just opinion. But so who of you think that the adipocyte or the fat cell is responsible for the pathogenesis of obesity? Raise your hand. The fat cell is a very important signaling system, lots of adipokines going around. Okay, who of you would actually think that the liver, as an organ that integrates a lot of signals, are responsible for obesity? There's a couple of votes there. Who think that the gut, as an important signaling system, telling you when you've eaten, when you've not eaten, who thinks the gut is responsible? There's a couple of votes for the gut. So we've heard about the brain. So who thinks this cortical areas of the brain, a bit of the brain that we use for decision-making, behavior, who thinks that? There's a couple of votes there. And then the final one is, who think that it's the subcortical areas of the brain that actually control the vital symptoms? A couple of votes. And a couple of people have voted more than once, which is also perfectly reasonable, because there's probably more than one explanation. But I'm going to try and simplify it and suggest to you, very similar to what Steve has said, that if we start thinking about the organ that is responsible for driving hunger or for reducing satiety, we really have to look at either the hypothalamus or the nucleus tractus solitarius. And now we're actually understanding that obesity could be, and I would suggest is, a disease of the subcortical areas of the brain. And suddenly, if you know what are the symptoms, hunger and lack of satiety, you know that the organ that we need to treat is the subcortical areas of the brain. Now suddenly, obesity can be a disease, and moreover, it's no longer a lack of moral fiber. Suddenly, a patient that walks into your surgery, you're not actually thinking, well, is this person just lazy and not very clever, and that's why they're obese? Or in fact, is it in fact that they have a disease of the subcortical areas of the brain that allows them to feel more hungry, or when they eat, not to feel satisfied when they've consumed a significant amount of calories? If we actually think of this disease in this way, now we have a ball game. Now we actually have a way to actually treat our patients in a compassionate way, because we understand that most diseases of the subcortical areas of the brain are tough to treat, but yet we are actually starting to get some tools. So how much weight do you have to lose to become healthier? It depends very much on what's wrong with you. But I'm also going to suggest that we've been going on about 5% weight loss for quite a long time, because no doubt 5% weight loss have a significant metabolic benefit. However, most patients that walk through my clinic door, if I offer them 5% weight loss, they were like, you know what, I'm not sure that that's worth it. So now the evidence is starting to point that actually, if we want to make a real difference when it comes to mortality and morbidity of many of the complications that people suffer, we need to have at least 10% weight loss. So that's also a game changer, because if you know that you actually have to treat a subcortical area, a subcortical disease of the brain, and you have to try to reduce hunger and fullness to the point where you get 10% weight loss, now we also have to be a little bit humble and say that we can't do that for everybody. We don't have the tools at the moment to do this for everyone. And now we also get into understanding that there will be responders and non-responders to our various treatments. I'm going to focus the pharmacological part of this talk on GLP-1 just because it's a really good example of how one hormone from the distal gut can actually help the beta cell, it can help the liver, it can reduce stomach emptying, but also the same hormone can actually influence the brain. And when it comes to the brain, it really can change appetite as such. So we understand that we can actually have multiple benefits with a single hormone, and we also now know, certainly from a bariatric surgery perspective, that there's lots of hormones interplaying with each other, and that's actually the combination of these hormones that probably are even more effective than any single hormone as such. But here is the scale obesity and prediabetes program and the one-year data with liraglutide 3 milligrams. And I will remind you that this was a double-blind randomized controlled trial, 2-to-1 randomization. 2 people got liraglutide versus 1 patient having placebo, 3,500 patients treated overall. Patients also had diet and exercise, but you would see that 8% of patients in the red line over here that was treated with diet plus exercise plus liraglutide 3 milligrams actually gained weight, while we actually see that 63% of patients on that treatment lost more than 5% of their weight, about a third lost more than 10%, and about 14% lost more than 15% of their weight. Now, when we started and we analyzed this data, the initial thought was, we can actually predict who is going to lose the most weight, because most people and most clinicians, and certainly most general practitioners, will say to us that we wait for the motivated patient to walk through the door, and if we see a motivated patient, we actually treat them with our medication. But within this clinical trial, we did all the psychological profiles known to man, we did all the biomarkers that you could possibly do, and when we tried to predict which patients were going to be the ones that lost 14% over here, and which were the ones that were actually going to gain weight on our treatment, we completely failed. The psychological predictive value of all the tests we did was 0. The motivation of the patient before they started did not predict how much weight they will lose. What did predict was the biology. So now if we're actually thinking about a subcortical brain disease where motivation, which is really driven by the cortical areas of the brain, cannot change how hungry you feel or how full you feel, it also allows us to actually treat our patients in a different way. You all are having a lovely dinner right now, but I bet you, just before this dinner was coming in, you felt a little bit peckish. But if I said to you, if you sit down for 5 minutes and just motivate yourself to feel less hungry, most of you would have failed. Because we cannot make ourselves feel less hungry by motivating ourselves. You can actually motivate yourself not to eat the food, but that's completely different from actually changing the cardinal symptom of hunger that we actually have. So we now understand that we actually cannot just treat the motivated patients, because certainly when I treat my rats either with surgery or with liraglutide, I've randomized my rats between seeing our dietitian and not seeing our dietitian, and they lose exactly the same amount of weight, because it's actually these treatments work through biology. We also know from the liraglutide studies that we can actually not only make people lose weight, but we can also reduce morbidity. We can reduce the number of patients that actually develop type 2 diabetes. And that really helps us in actually understanding how valuable these treatments are. But when we look at the predictors leading to stopping rules, and we can actually look at all the different treatments. We have orlistat here, we have naltrexone, bupropion, liraglutide, lorcaserin, and also even phentermine and topiramate. We can see that all of these treatments actually start sort of coming together with suggesting that you can tell at 12 weeks how much weight somebody is going to lose by seeing if they cross the magic threshold of 5%. So it appears that the biology of the response can be told by 12 weeks of treatment. And it turns out in the look-ahead study that used diet and exercise, we could see the same predictive value at 12 weeks. So people that are biologically able to lose weight with the treatment are actually able to go on and lose significant amounts further. However, if somebody does not lose weight after 12 weeks on your treatment, my strong suggestion is to discontinue that treatment and to try something else. And not to think that it's your failure, that you haven't tried a right treatment, or that the patient hasn't listened to you, or that the drug is rubbish. In fact, it's just the biology at the moment is such that we cannot actually go on after 12 weeks, because if they don't respond after 12 weeks, they are not going to respond within 12 years on that therapeutic approach. And here we can see those patients that actually responded and did not, or rather here the ones at the bottom in the solid line that responded to the treatment, who've lost more than 5% of their body weight within 12 weeks on top dose, versus those patients that did not respond. And that really helps us, because the last thing that we want to do as clinicians are actually treating patients such as these in the broken lines who do not respond to our drugs and yet clock up all the side effects associated with the medication. So if a patient do not respond, please do stop the medication and try something else. What we do, however, see is when we actually look at those patients who respond, we can see that almost a quarter of patients are able to lose 15% of their body weight when treated with diet, exercise, and liraglutide. Now, 15% body weight loss, again, is a very significant amount of benefit that we're buying people. We can see half of patients are actually able to lose 10% of their body weight. And again, I would suggest that that should really be our target when we're treating patients. Because at 10% weight loss, we actually have patients engaged and they will continue the treatment for life. Because we know the minute they discontinue the treatment, that actually all the body weight will come back. And I remember growing up in lipid clinics, and the first question that most patients actually asked us when we started statins was, "So doctor, when can I stop my statin?" And our response was, the minute you want to start regrowing your atherosclerotic plaque. Because the minute we stop our statin, we actually regrow our plaques. So the minute we discontinue our treatment, be that diet, exercise, medication, or surgery, we will actually regain our weight. And that is probably the hardest part of the discussion to have with the patient. Most patients don't mind taking a treatment. Most patients don't mind taking an injection to actually lose weight, or taking a diet, or having an operation. But very few people actually think of this as a lifelong therapy. Because most of our patients think that once they've actually been able to achieve the body weight, then they will just use their motivation to actually keep their body weight down. But we've just shown, and Steve has just eloquently showed you, that it's nothing to do with motivation. It has to do with compliance, of course. If you don't take the medication, it won't work. But whether or not you're motivated or unmotivated, as long as you're compliant, you actually will have an effect. So we have to actually have those difficult conversations early on, that patients actually understand these are treatments for life. And therefore, our approach, as John Dixon has very often said, this is a chronic disease management. And you as general practitioners are far better than we in our ivory towers at actually managing chronic diseases in the long term. So a typical strategy that is suggested is, we can start often with self-directed lifestyle changes, then move on to more professionally directed changes, add medication, consider surgery, or actually even consider combinations with surgery and medication. So what I would like us to actually move to is actually think about moving through this algorithm in a sensible way, but actually not to get stuck. Because there are patients that's just not going to respond to the lifestyle changes. And we know in Look Ahead, 2 in 10 patients responded really well, but 8 in 10 patients did not achieve 10% weight loss. We know with medication that we can maybe treat as many as a third or even half of patients that will respond to our medication, but half will not. And even when it comes to surgery, we actually see that there's a significant number of people who do not respond to surgery, not because they're not motivated or not smart enough, but merely because the biology of the disease is such that even surgery is not sufficient. So I'm going to conclude and suggest to you that obesity is a complex and chronic disease of the subcortical areas of the brain. It has enormous impact on individuals, health systems, and society. But I think we're at the dawn of a personalized medicine approach where we'll be able to get the right treatment to the right patient at the right time. And as we are gaining more tools in our toolbox, I will urge you to use those tools. And if they don't work, put them back in the toolbox and try them for somebody else. And if a tool doesn't work in one person, try another tool, because it's not a failure of the patient to respond. It's not a failure of our system to respond. We will get better as time goes on, especially as we have more tools available to us. So please allow me to thank the team that's at home doing all the hard work, of course, and our international collaborators. So thank you very much.